Hello everyone. In this lecture, we'll discuss the management of neonatal hyperbilirubinemia. We've already covered the key definitions, pathophysiology and causes of neonatal jaundice, along with acute bilirubin encephalopathy and Kernicterus in detail in the previous lecture. If you haven't watched that yet, I highly recommend starting with that lecture first. You'll find its link in the description box below. When discussing management, I'll primarily refer to this 2022 AAP paper, with a disclaimer that its recommendations, they're mainly intended to be used for developed countries. Additionally, these guidelines, they apply to infants who are born at or beyond 35 weeks of gestation, and therefore we have late preterms, terms, and post-term neonates who are included in this. These recommendations, they outline several key action plans, some of which we'll discuss in this lecture. The first is determining when to measure total serum bilirubin. We all use transcutaneous bilirubinometer in screening hyperbilirubinemia because the TCB values, they correlate very well to the TSB values, but there's always a margin of error of 3 units. And therefore, whenever TCB exceeds or is within 3 units of the phototherapy threshold, TSB should be measured. Also, the TCB values are less reliable when they are at or beyond 15 units, and therefore any TCB which is higher than 15 or equal to 15, it should also prompt a TSB measurement. And whenever this TSB exceeds the phototherapy threshold, intensive phototherapy should be initiated. The earlier nomograms, they categorized phototherapy thresholds into 3 risk categories: low, medium, and high. The low risk category comprising of healthy term-born neonates, and with healthy I mean they have no additional neurotoxicity risk factors, while the term-borns with an additional risk factor for neurotoxicity were included in medium risk group, along with late preterms without any additional risk factors. Whereas the high risk category, it comprised of the late preterms who had an additional neurotoxicity risk factor, meaning that they had the lowest threshold for starting intensive phototherapy. The updated nomograms, however, they offer a more refined week-by-week risk stratification for phototherapy threshold. This particular nomogram, it outlines cutoffs for neonates who have no neurotoxicity risk factors other than their gestational age. In contrast, this one provides week-by-week risk cutoffs or stratification for infants with additional neurotoxicity risk factors such as hypoalbuminemia, any type of hemolytic disorder, sepsis, or any significant clinical instability in the previous 24 hours. We've covered these risk factors in detail in our previous lecture. The newer guidelines, they also introduced a concept of escalation of care and escalation of care threshold. Escalation of care threshold is defined as total serum bilirubin 2 units below the exchange transfusion threshold. For example, in a healthy 38-weeker at 72 hours of life, the cutoff for exchange is 26 units, and therefore 2 units below this, at 24 units, we need to escalate our care, since 24 units is the escalation of care threshold. Similarly, in a 38-weeker with additional neurotoxicity risk factors, at 72 hours of life, the cutoff or threshold for exchange is 22 units, and therefore at 20 units we need to escalate our care, 20 units being the escalation of care threshold. This proactive approach, it helps in early intervention and reduces the risk of bilirubin-induced neurotoxicity. Let's go through a few cases. This first case is a neonate who presented at 72 hours of life with history of poor.
This was at admission of case 1. As you can see, this baby was deeply icteric palms and soles, and baby here was having stereotypic.
Now, as you've seen, this particular child was very irritable, was having a shrill cry along with retrocollis and opisthotonous posturing, and the child also had stereotypical bicycling paddling movements. The mother was O negative and the child came DCT positive. The child was also having hypoalbuminemia. So the child had 2 neurotoxicity risk factors, positive DCT and 2.9 units of albumin. Neurological examination was suggestive of a bind score of 7, indicating severe ABE status. The TSB, however, was 0.5 units below the exchange threshold. But since the escalation of care threshold is 20 units, we escalate care for this child. The second case, this is a 38-weeker presenting at 60 hours of life with yellowish discoloration of skin and decreased urine output. Otherwise, the child is active, has normal tone, and is actively rooting for milk. The child has a negative density, and a significant weight loss is, however, noticed because of poor feeding. Poor feeding was because of poor latching. The mother was having inverted nipples. Otherwise, this child has no additional neurotoxicity risk factors. Serum albumin is also normal, 3.5 units. But the TSV is 26 unit, 1 unit above the threshold for transfusion. So even for this child, obviously, we'll start escalation of care. When we talk about escalation of care, what we mean by it, we admit the baby in a tier 3 NICU, preferably directly into the NICU rather than admitting the child to an emergency department. We take essential blood samples and notify the blood bank that we'll soon need a DVET. Then we start hydrating the child extensively, and we measure TSV every 2 hours. This is very important that we follow up this child very, very extensively. And if at all the child is DCT positive, then we start IVIG therapy as well at this particular time. If at any point during the escalation of care, there is evidence of moderate to severe acute bilirubin encephalopathy, or the latest TSV is at or above the exchange threshold, we go ahead with an exchange transfusion, an urgent exchange transfusion. However, if that's not the case, we continue with escalation of care until the TSV values come below the escalation threshold. Here's a comparative analysis of our cases. Case 1 presented at 72 hours of life, had hypoalbuminemia and a positive DCT. Therefore, neurotoxicity risk factors were present in this case. And the child was already having a severe ABE to begin with. Even though the TSB was below the threshold for exchange, we go ahead with exchange transfusion because there is severe ABE. Case 2, however, had no ABE to begin with, had no neurotoxicity risk factors as well, but TSB was above the threshold for exchange, and therefore even in this case, we do go ahead with exchange transfusion. But there's a loophole. In this particular case, since there is no ABE as yet, we start escalation of care. And during escalation of care, if the latest TSV, it falls below the exchange threshold and the baby still shows no signs of moderate or severe ABE, you have a choice to defer exchange while continuing with intensive phototherapy and hydration with frequent monitoring. This approach aligns with our key action statement 23, which emphasizes on individualized decision making based on ABE signs and TSB trends. What it says is if while preparing for the exchange transfusion, but before starting the exchange transfusion, a TSB concentration is below the exchange threshold and the infant does not show any signs of intermediate or advanced stages of ABE, then the exchange may be deferred while continuing intensive phototherapy and following the TSB every 2 hours until TSB is below the escalation of care threshold. So do we have an objective score which helps us in taking decision? Yes, we have bilirubin to albumin ratio. This bilirubin to albumin ratio, as we had read in our previous lecture, is a key indicator of free bilirubin level, and free bilirubin is the one which poses neurotoxicity. There are established cutoff values based on gestational age and neurotoxicity risk factors. For a full-term baby with no neurotoxicity risk factors, the cutoff is 8, and therefore this baby is safe. Whereas for this full-term baby, if there are any neurotoxicity risk factors present, the cutoff lowers down to 7.2, and therefore this child is not safe and exchange transfusion is justified. For a late preterm child with no neurotoxicity risk factor, the cutoff is 7.2. Whereas for a late preterm with any single neurotoxicity risk factor, the cutoff further lowers down to 6.8. I'll provide a link to this paper in the description box. Feel free to go through it for a detailed understanding of these action plans. And these guidelines, as we've read, they apply to the late preterm, term and post-term neonates. For neonates who are born before 35 weeks of gestation, we follow the cutoffs provided in this particular paper. However, it is important to note that even these cutoffs, they are based on expert opinion and they are not very based on strong evidence. Unlike late preterm, term and post-term neonates, we do not have our specific thresholds available for these kids. Instead, bilirubin management in this population, it is guided by gestational age and post-menstrual age. So a 28-weeker at 2 weeks post-menstrual age will fall in this particular category. With these considerations in mind, selecting the right phototherapy equipment is crucial for ensuring effective and safe treatment. The most effective and the safest devices to administer phototherapy, as recommended by AAP, they incorporate narrow band blue-green light with an optimal wavelength of around 478 nanometers. And the spectral irradiance of the device should be at least 30 microvolt per centimeter square per nanometer. And the device should be placed in such a manner that it illuminates at least 30 to 80% of the body surface area of the neonate. More than 80% is not sort of achievable because there is nappy and there is eye shield as well. So we should ensure that we use a very small nappy and expose as much as the body surface area as possible. Change of position is not recommended. Maybe a double and triple surface phototherapy is still recommended, but change of position of the kid is not recommended. Now, when this narrow spectrum blue-green light with an optimal wavelength of around 478 nanometers, it falls on the exposed surface of skin, 3 photochemical processes they take place. First is photoisomerism. Then we have structural isomerism. And the last is photooxidation. Photoisomerism, it leads to immediate conversion of insoluble forms into the soluble forms, but it is a transient and reversible phenomenon. Structural isomerism, on the other hand, it takes time, but it is a permanent phenomenon and therefore it holds more credibility. Photooxidation is the least important phenomenon for converting insoluble form into the soluble form, but it is anyway important because it has been linked to increasing oxidative stress to the baby. Because it increases the oxidative stress, it raises concern about potential long-term effects of phototherapy. Prolonged phototherapy has been associated with conditions like childhood epilepsy and leukemia. Though no causal relationship, it hasn't yet been established, but these are real concerns. While these concerns, they warrant a careful monitoring, it is important to balance them with the well-established benefits of phototherapy in preventing severe hyperbilirubinemia and its complications. Having said that, phototherapy is generally considered very, very safe, and none of these associations have been proven to be positive. The established side effects, they are mostly mild, transient, or manageable, and they include temperature instability, dehydration due to insensible water loss or loose stools, a transient mild erythematous rash, brown baby syndrome, and a potential retinal damage, which too has been demonstrated in animal models. It hasn't yet been observed in humans, and such a study will not anyway be ethical to conduct where we do not place eye shields for a child receiving phototherapy. Let's look at a clinical case. So this is a full-term neonate who presented with the TSV beyond threshold on day 1 of life and was found to be DCT positive. The baby was started on intensive phototherapy and subsequently developed bronze discoloration of skin, which however gradually faded over the course of few months. This condition, known as bronze baby syndrome, it occurs in association with direct hyperbilirubinemia. And therefore, you need to rule out liver dysfunction in such a kid. But in absence of liver dysfunction, it is typically a mild and transient phenomena, as demonstrated in these follow-up images. All of the discoloration, it goes away after a few months. So that is it. To summarize, phototherapy, it remains a very highly effective and generally safe treatment for neonatal jaundice when used appropriately. Understanding its mechanisms, potential risks, and recent guideline recommendations, they help us optimize care while ensuring the best outcomes for our tiny patients. I hope you found this discussion helpful. If you did, don't forget to like, share, and subscribe to my channel. Feel free to drop your questions or topic suggestions in the comments below. I'd love to hear from you. Thanks for watching, and I'll see you in the next one.